you may not have hyper or hypo, but you have some thyroid problem going on, and that was also quite common in the population. Then coming to other disorders that we should be aware of, I mean, which we should be, which may not present to us very easily, may not come to us very commonly, is osteoporosis. And bone health is another important aspect that we should always think about. I mean, keep in mind, because this is a common problem in women over the age of menopause. I mean, over 50 years of age, and also in men. We find that men also over the age of 70 are particularly prone to have osteoporosis. And one of the important points about osteoporosis is that it's a silent problem, and it may present with fracture. So that is another problem. To complete the list, I would say other aspects that we should look at is polycystic ovarian syndrome in women, in young women. This is another important endocrine problem that we all see very often. And then there are rare conditions like hypertension. Endocrine hypertension is again an issue which we may discuss about.
Okay.
And then just to complete, adrenal disorders like Cushing's or Addison's also we should be aware of. So I think these are the problems that we should be knowing a little about.
Okay. So now you have very nicely said about the prevalence of hypothyroidism, which is so common, and looking at the number. You think should thyroid screening be a part of a routine or an annual checkup or a part of screening? Like now, sugar has been universally accepted as a part of routine screening. But looking at the numbers, what you have shown, you think it should be a part of routine screening?
Well, I mean, in the sense that one good thing is that now it is very easily done. The labs have improved all over the country, and we have good tests available. We have the enzyme linked immunoassays, or the CLIA is one test which is very good for doing the hormonal assays. So earlier people used to do with the radio immunoassay, and it was very difficult doing the tests, and it was not available in at least in the tier 2 cities, or and most of the times it was even in a city, from a city like Hyderabad, people used to say that the test is sent to Mumbai to get the report. So that used to be the scenario 10 years or 15 years back. But now I think everywhere we have very good equipment available, which is with which it is immediately done. So the question comes whether we should do it routinely as a screening. So there are advantages of doing that. There are probably some disadvantages also, as you would see. The advantages are that we know that thyroid disorders, I mean, hypothyroidism particularly is many times silent. It may not be picked up. It's a very gradually developing condition, and it may be associated with significant problems also, like it may predispose the individual to cardiovascular diseases, increase atherosclerosis and all that. That can happen. And it can also present with varied manifestations. So that is, so keeping that in mind, it may be good to pick up hypothyroidism. It may be good to do the screening, because we're saying that 10% of the population is affected. But the other aspect of it is that, very often we find a lot of people having subclinical thyroid diseases, and they, not all of them require treatment. And then we have a lot of unnecessary work that is coming up, because we are trying to look at all these people who have got subclinical hypothyroidism, that is a mildly elevated TSH with normal T3, T4 is what is called as subclinical hypothyroidism. So that may not always be a problem. In some subsets of people, it requires treatment, but many of them don't require treatment, and that again adds up to our list of unnecessary problems that we have to tackle. So that is the downside of regularly screening, routinely screening for thyroid disorders.
Right. So we have seen that there are both sides of the coin, and there are plus points where you can pick up somebody other who has not manifested but has got definitely significant hypothyroidism, versus somebody who has just a borderline subclinical and doesn't require treatment and unnecessarily may get over treated. So that is one thing. So now, what happens, that quite a few health checkup packages which are done in the city, I'm sure it is, be it Hyderabad or be it Mumbai, now they include TSH as a screening test, and somebody who has been detected as a serum TSH anywhere between 5 to 10, they are not a known, and they will go back with their report to the family physician that they have shown the report as abnormal because it will be written in red that it is 7 or 8. So what should we do further? Are we suffering? Because they are asymptomatic. Only during the health checkup it has been detected that TSH, which is the single test which is done, and anywhere found between 5 to 10. How should the family physician approach further?
Yeah. So that actually, you raised a very important problem that is faced by most of us, is that we see a lot of people who have gone for a test as a routine, and they have found that the TSH is between 5 to 10, which is called a subclinical, as I just defined it, that it is subclinical hypothyroidism. So now, who requires treatment in this? There is, not everybody requires treatment, because what we see is that half of them may actually become normal also after some time. If you follow them up, they may become normal also. So, but some of them progress. So what we want to actually do is identify those who are going to progress to more severe disease, and those who are going to require treatment. So the challenge is to identify those people. So and those who are going to suffer from not being treated. So we can put it into two or three different groups. The ones who require treatment. One is, if you're dealing with a woman who's planning to conceive, and who's trying to conceive and has infertility and all that, she definitely requires treatment for subclinical hypothyroidism also, even because mild degrees of thyroid function actually interfere with ovulation and can interfere with conception. So that lady definitely requires treatment. Then somebody who's not growing well, a child who's not growing well, has got subclinical hypothyroidism, probably he will also benefit from treatment. Then you have got people who have got a gland which is enlarged, thyroid gland which is enlarged, a goiter which is there, and such people, if they have subclinical hypothyroidism, because the TSH is a important factor which facilitates the growth of the thyroid hormone, or which promotes the growth of the thyroid gland. So a higher than normal TSH level facilitates the growth of the gland. So therefore, we want to suppress that. We want to use thyroxine in such people, and see that their TSH is kept in the normal range. So that is another group of people. Then we have got people who have got very high antibody levels. So these could be individuals with other autoimmune conditions like type 1 diabetes, or problems like this. So they have got very high antibody titers. They require treatment. And then somebody who has got overt symptoms of hypothyroidism means he has got a lot of tiredness, he has got weight gain, he has got classical symptoms of hypothyroidism, even though his TSH is not very high. In this situation, this is another group of people who may require treatment. But there are apart from these groups of people who definitely require treatment, there are a large number of people who don't require, who are asymptomatic, even with their TSH of 6-7. They may not actually have any symptoms. They are not having any of these problems that we have discussed about, and so they don't require treatment. And one more category which I forgot was even women who are pregnant. During pregnancy, if it is detected the subclinical hypothyroidism, it has a significant impact on the maternal outcomes, and therefore they also require treatment.
Okay. Now here you raised a very important issue about those who have a thyroid antibodies positive may require a treatment. So should all those subjects of subclinical hypothyroidism should be asked for getting a thyroid antibodies done, and if which are both antimicrosomal antibody as well as anti-thyroglobulin both required, or any single will do, or how to, because the antibody test itself that is pretty expensive. So at
Yes.
a family physician level, how should they proceed?
Yes. Again, I think the antibody issue can sort of, in the sense we don't. I would say that we don't routinely need to do antibodies in everybody, but as I was mentioning that, if people have got some other evidence of autoimmunity in the form of, type 1 diabetes or any other conditions, there, the antibodies are going to be their autoimmune status is going to affect their development of thyroid diseases and the progression of that, and therefore we need to treat them. Now the antibody levels can be done in some subsets of people, like again we said, those who are planning to conceive, and those who have got whom we are persistently their TSH is in that border zone. Again, we have repeated after a few months, and again it is maintaining in that zone only. So then we can do the antibodies. I think in the first instance itself, antibody probably makes it more confusing, because antibody again is the extent to which the antibody elevation is also important. So if the antibody is just above the normal, if the 30 is the cutoff range and it's 32 or 34, That is not elevation. Antibody elevation would mean at least about a four-fold or eight-fold or ten-fold elevation of the antibodies are there. Then it is significant. It's not just a little above the border cutoff value is not significant. So that's another important point that you raised, Dr. Ketan. I think that's important. That I don't think we should suggest antibody levels for everybody, but
Correct.
should be in people who have got persistently in that subclinical zone, or if you are worried about conceiving. I mean, there are women who are worried about conceiving, and in such situations we may get the antibody levels. But I think, as you rightly pointed out, not everybody requires antibody.
Okay. Now that was one aspect. Second aspect is when we see a subclinical hypothyroidism. Now asking for T3, T4. Now there are free T3, free T4, total T3, total T4. So whether before starting therapy does each and every individual requires, and if yes, what it will be, free levels or total levels?
Yeah. So actually, if you before I answer the question directly, I would just like to give a brief idea about that, about the difficulty about doing the tests and all that. So if you look at it, the thyroid hormones are circulating bound to plasma proteins like the globulins, the albumin, and pre-albumin, and it the thyroid hormones are not totally I mean, some, I mean, they're bound to this to the proteins, and some of it is free. The free ones are the active ones. Now, when you measure the total, I mean, the thyroid hormones, when we speak of, we don't specify whether it's the free or the total. It is generally the total that we're measuring. So when we're measuring the total, that the doing the total measurements is easier. For doing the free measurements, if you want to have a good accuracy and good reliability of the test, it has to be done by equivalent dialysis. I mean, you have to separate the free fraction from the bound fraction and then measure the free fraction. So that often is not that facility is not available everywhere. So whatever is done in most of the labs is not a very good way of assessment of the free hormones. So that limitation we should know. So now, if we ask for free hormones, there should be some specific reasons why we ask for it, and we should be aware of a lab which does it reliably, and then only get it done. Otherwise, getting the free hormones done for every patient is not actually required, not required. But what we often see is that when you get a report of a subclinical hypothyroidism, the first statement that is written is that advised to get free hormones done, which is not actually required. So the situations where a free hormone requirement is there is in conditions where you have a confusion. Like in pregnancy, what happens is that the thyroid binding drop because of the effect of estrogens. And same thing happens even in people who are taking estrogen blockers. I mean, estrogen pills, if somebody is on OCPs or somebody is having certain other drugs also can interfere with the, I mean, increase the PBG levels, and these people can have an increase in total thyroxine levels. So there is a role for doing a free hormones. Otherwise, there is no role for doing the free hormones. So even in pregnancy, now what we have seen is that because of the difficulty in doing the test, or rather the reliability of doing the test, there's no difficulty, because what we see is that every lab, even if they're not having the facility to do a test, they just take the sample, they get it done somewhere, and they send it somewhere, they get it done, and they give you a report. So the problem is whether I mean, we are happy with the reliability of the report or not. That is the major problem nowadays. Probably there is no difficulty in getting a test, because any lab you go to, even a very small lab which doesn't have the equipment, they generally collect the samples and try to get it done somewhere and get back to you with the report. So the reliability is an issue. So what has been recommended by most of the professional organizations and professional bodies is that even in pregnancy, where free hormones are important, we are saying that the free hormones are important. What we are saying is that you don't need to get the free hormones done for everybody. What you can do is you can use a correction factor, and use a correction factor of 1.5 times of the upper limit of normal as the cutoff for using the total hormones. So if you are looking at T4 level in a usual report, you will find that the upper limit of T4 would be 12. So in pregnancy, you have to use a cutoff of 18. So if total T4 is less than 18, then you can assume that it is normal. If it is more than that, then you assume that then you have to look at see that it is abnormal. And similarly, for the T3 again, it is again 1.5 times of the upper limit of normal given by that lab. So that can be a useful tool for assessing whether the levels are normal or normal, and you don't need to get a free hormone done every time.
Okay. So, because we know the cost of free levels are definitely more expensive than getting the total levels done. So that is another factor. And as Dr. Rakesh has already mentioned that we don't need to get the free levels for each and every individual. So probably it is a very, very small niche area where only we will require these free levels to be checked. Second things what we have observed is quite often, people get out of fashion the thyroid function test done where T4 is already low, TSH is elevated, and then it has been ordered to check the free T4 level. Now, once if you have a total T4 already low, there is no role of asking for a free T4. So there is absolutely, in fact, sometimes it may happen that T4, total T4 that is can be normal, but free T4 can be low, and that would be a very niche area again. So you need to be rightly selecting that when you want to ask for a free levels, otherwise it will be just a waste of money. Okay, so now Dr. Rakesh has mentioned about these areas. Now, Rakesh, there are some people who will present with a goiter. Now, there is a goiter, there is a pain, and then the thyroid functions could be either showing a normal thyroid function test or showing abnormalities in there. So, how should the family physician approach? They have a goiter and a painful pain in the throat.
So basically, what you have to look at is that somebody presenting with a thyroid or goit, as we call it. So that can be, like a diffuse swelling can be there. Diffuse swelling can be there as part of, a thyroiditis, which is their inflammation of the entire gland, which happens in patients who are present with hypothyroidism. That can be a classical, picture that you see that they have got a diffusely enlarged gland and they have features of hypothyroidism. They require to be treated with thyroxine, and you don't require to do any further tests for that. You don't require FNAC, you don't require any other tests as long as you find that the TSH is elevated and you start treating them. Now, there's the other group of people who present with a nodule within the gland. That is, the whole gland is not enlarged, but only a part of the gland is enlarged. There's a nodule in the either the right lobe or the left lobe. There's a nodule. A well-defined nodule is there. So, in such people, what happens is that you have to now look at the characteristics of the nodule to understand whether it is a benign nodule or is it going to be is it showing any features of any suspicious features which would suggest that it can be malignant. So those that is what comes to our mind, and that is what we have to differentiate a benign nodule from a suspicious nodule, and decide whether they need to go for surgery or not. Because what we know is that if you look at autopsy data, so the nodules are very common. They are common in say about at least about 40 to 50% of people have nodules at some time or the other. So these nodules may be very small. They may not be palpable in everybody. If you do ultrasound for everybody in the population, you'll find that at least 40% people will have nodules. Even autopsy data has shown that a lot of people have at least 40 to 60% of autopsies. I mean, have thyroid nodules. So thyroid nodules are very common. Thyroid nodules are not uncommon; they are very common. Now, you can't operate all these 40% of the population. If you're going to operate, then you're going to end up doing, doing a lot of harm than good. So we have to identify which of these nodules are is having a suspicious features, which would suggest that it's going to become malignant. So there you need to treat. So that is about just about 5% of all the nodules, a very small percentage of the nodules actually require surgery. So how do you pick up those? You can do now. You have got good ways of doing it. One is that you do ultrasound. Ultrasound has picked up as a very good modality of investigation for the thyroid nodules. There's been a lot of developments in ultrasound. Now you've got these probes which are 8 megahertz probes, which help in doing a very good picture of the imaging of the thyroid, and that is particularly better than all the other imaging modalities. Ultrasound of the thyroid, where you can pick up, where you can look at features like what is a characteristic of the nodule, whether they're hypoechoic or hyperechoic. So hypoechoic nodules are the ones which we are worried about, and then within the hypoechoic also, how when we look at the margins of the nodule, we look at the vascularity, Then we look at whether it is extending, into the surrounding thyroid tissue or not, or whether it's a well localized nodule. And then we look at whether the nodule is taller or wider. In the sense that if the nodules is more wider anterior posterior, then they are more likely to be there. That is another feature which is adding to the suspicious features characteristics. And if there is spectral calcification within that. So these are characteristics which you should look for. And if they are there, then we have a very high suspicion. We have got a Thyroid's classification is as is called the thyroid classification with the ultrasonography. And so Thyroids 4, 5, and 6 are the ones which are very significantly require further evaluation and treatment. Thyroids 2 is benign, 1 is indefinite. Where the characteristics are not seen at all. Not understood clearly, not clearly discernible. And 3 has got about a 5 to 10% chance of having pregnancy, and 2 is, you can say, is less than 5% chance. So it's almost benign. So that is how you have a classification based on the ultrasonographic features system. You have specific ultrasonographic features which can suggest that there is a high risk of malignancy in that nodule. That is one thing that you look at. Then you have got FNAC. So once you have the ultrasound features, then you advise FNAC, where again you can do a ultrasound guided FNAC. That is even better, because when you identify some suspicious area, then the ultrasonographically you can do a guided FNAC from that part of the nodule and get more information. And that again has got a characterization based on a system called Bethesda classification. It's classified as again into 1 to 5, and 4 and 5 are the ones which are very significantly giving us a risk of malignancy. 2 is say benign, and 3 is again an intermediate one. So that is how we use these two tools to understand that. And the other important thing is that also clinically look for any signs of compression, whether there's any difficulty in breathing, difficulty in swallowing, and so these are things, or if there's any venous return is interfered with the thyroid nodule. So those things are there. Then you know that that requires to be removed. Otherwise, they don't require removal.
So that's a very important message Dr. Rakesh is given over here, that accidentally detected a single nodule which could be found in a large population. You don't have to go on investigating it. Don't go for FNSE for each and every subject. So it could be just an accidental finding. So mind it, is it been done specifically, or it has been accidentally picked up and we need to pick it up. Now, Rakesh, because our...
Just to add one more point, just to add one more point, what I would like to say is that less than 1 centimeter nodules don't even require evaluation. What is that, if it is less than 1 centimeter, that is less than 10 millimeters, nodules don't even require evaluation. More than that only, then you think of doing FNAC, to think of looking at the characteristics and all that. Very small ones, don't even bother about them.
Fantastic. That's a very important message which has come, that we need to really look it into whether this requires further evaluation or no. And second, of course, when we are having in mind or which subjects we should ask for FNAC, again we have a choice whether to go for a blind FNAC or with the ultrasound guided FNAC which is there. Okay, now of course our vast majority of family physicians have been treating levothyroxine therapy for the hypothyroidism and all. They are all well versed with it. Can you just throw some light about titration of the dosage? Because sometimes they start the therapy with, say, for example, 50 microgram, and they said we will repeat after 1 week. So you just have to give them that what is the right time before which, or after, it should not be too early or too late to repeat the test before we titrate the dose.
Yeah. So I think what I would like to highlight here is that for at least some of the older people in the audience, that earlier days, about 20 years back, we used to just go with the symptoms. 20-30 years back, we used to go more with symptoms, because we didn't have very good TSH assays. Now the TSH assays, as we spoke about the thyroid hormone assays becoming much better and all that, now we have got this third generation assays where you can have a very low detectable limit of TSH. So what we are trying to see is that if we are overdoing something, if we are giving excess dose also, it is not very good, because what we know is that excess of thyroxine can promote osteoporosis in older women, and then it can actually cause it can cause atrial fibrillation, it can promote the development of atrial fibrillation. So these issues are there. So therefore, we don't want to overdo it. So earlier days, it used to be, because we didn't have these assays, people used to just increase the dose based on the symptomatology and all. So now since we have these tests available, we would like to. And then the other thing is, because these tests are available, now we have different strengths of medication also available. Otherwise, you just had only 100 micrograms available, and people used to go in multiples of that, only 1, 2, 3 tablets, or 1.5 at the most. You could do 1.5 or something like that. So now, with the tests available, more reliable tests available, we are even doing, like, we have got strengths from 12.5 to 150 available. Different strengths are available, so you can use them appropriately. But the point that, as Dr. Ketan Mehta has said, that you have to not do it within a week, because it's not going to change within a week. The thyroid hormone, what we should know is that the duration of action, I mean, the half-life of thyroxine is about 7 days. So when you start giving it, I mean, it takes a few, at least a week or 2 weeks, 2 weeks to sort of come to a stable level, and then to get the TSH appropriately adjusted, because the TSH is a good indicator of showing whether the dose is appropriate or inappropriate. What we are doing, we are using TSH as an indicator. So for the TSH to stabilize at a particular dose of thyroxine, it takes at least about 6 to 8 weeks. So 6 weeks is the earliest, I would say, or 8 weeks optimally. If you do want to do 8 to 12 weeks, if you're not in a hurry, say suppose somebody who's got who's on a lifelong therapy, I mean, who doesn't have any significant symptoms because of this, and you have started medication, or he's already on medication, don't do it within, I mean, you've made a change in the medication, don't do it again before 3 months. Wait for 3 months. That is ideal. If you want to, the earliest time to assess is about 6 to 8 weeks. Earliest time to assess a change is 6 to 8 weeks. Optimal, I would say, is 12 weeks, if you, I mean, or 3 months, if you have no hurry to go about with it. Sometimes you may have a bit of a hurry, because you have a problem, you want to operate a person, and you are seeing that. So maybe in a very rare situation, you may do it within 2 weeks, you may do it and see. But otherwise, generally, I would not suggest you to repeat it within a week or 2 weeks. You just wait for at least about 6 weeks to do it. And optimal time, 6 to 8 weeks, is the earliest you can do. Optimal time is 12 weeks. So if you're dealing with somebody who's been on long-term replacement, or who doesn't have significant symptoms, you've picked up that is, you've done his tests, and you found that the TSH of his been gaining weight, he's been feeling lethargic and all that. You do a TSH, it is, say, more than 100, and then you start treatment, and you can just do it after 3 months. And then if you make a change again, if you reach the optimal level of TSH, then do it next is only 6 months later, and 6 months to 1 year later. But if you are making a change in the dosing, just to know whether the change is appropriate or not, do it after three months.
Okay. Rakesh, you mentioned about the subclinical hypothyroidism beginning. Now, similarly, what about subclinical hyperthyroidism? So, which is also been detected, and how should the doctor should approach for that?
Yeah. So what I could say is that subclinical hyperthyroidism is first to define that it is a condition where you have a low TSH but normal T4 and T3. So it's not a overt hyperthyroidism. Overt hyperthyroidism will have high T4, T3, and a very low TSH. So here the TSH could be either in the zone of normal lower limits is, say, zero 0.4 or 0.5. So 0.5 to 0.1 is a stage 1, you could say, of subclinical hyperthyroidism, or category 1, and category 2 is when it's lower than the 0.1. So so these are the two categories, you could say. So those who are in category 1, you just have to watch them and see what is the cause for that. Common causes could be that a person is on medication, is getting a little more medication than is required. The second common cause could be this what do you call as subacute thyroiditis, which can present initially with a phase of thyrotoxicosis, because whatever preformed hormone is there in the gland is released, and then you have a phase of subclinical hyperthyroidism, and then they go into hypothyroidism later on. So that could be another category. That is another big category. So these are two major categories that you may see. Then there are others, like older people may have a Graves' disease, which is smoldering, and there they require. So that is one category which requires treatment. The first two categories probably just require adjustment in the dose of reducing the dose of thyroxine, or just waiting and watching in the second category, where we know that this person is going to go into hypothyroidism. We don't have to start treatment with antithyroid medications. Wait for him to go into hypothyroidism and start medication at that time. And in the third category is the one where we have to identify those who are likely to have problems because of that, who are going to have where their TSH levels are more than less than zero point 0.1, and these are the ones whom we have to identify. We may sometimes need to do a thyroid scan also, because what happens is that we are trying to see what is the cause, whether it is this thyroiditis where it is transient versus somebody who's got a more long-standing problem of increased activity in the gland. So the thyroid technetium scan, which picks up activity, that is, if the technetium is picked up adequately by the gland, if it is diffusely picked up, it's Graves' disease. If it is picked up in some particular portion, then it is a toxic multinodular goiter. Or if it is not picked up at all, if it is not picked up at all, it means that it is a thyroiditis where there is a destruction of the gland because of the autoimmunity, and such a person has a self-limited condition which will settle down within a few days. So this is how you have to tackle with subclinical hyperthyroidism. One
Okay.
and one, I mean, just a broad principle which I would like to say, which would make it easy for people to understand, is that when you're dealing with subclinical hypothyroidism, what you have to understand is that you are erring on the side of treatment. That is, you want to treat the younger people, because what happens is that they will benefit more from treatment of subclinical hypothyroidism. The older people will not benefit. Older people will have more harm of treatment rather than benefit of treatment. The mirror image is for subclinical hyperthyroidism. So there you want to treat the older people, because they are at more risk of developing osteoporosis or atrial fibrillation because of this continuing subclinical hyperthyroidism. Whereas the younger people are not going to have much harm. So the younger people will not want to treat them, but the older people you would like to treat for the subclinical hyperthyroidism. For when you come to subclinical hypothyroidism, you are more inclined towards treating the younger people and not treating the older.
Okay. So now you mentioned about the treatment of one, especially in elderly people. So be it on either direction, any cutoff values of TSH which you will be looking out for. So for hypothyroidism, we always look at the TSH levels. In hyperthyroidism, will the treatment still depends on TSH level, or it will also depend on the T4 level?
Yeah. So in hyperthyroidism, what we are saying is that you're looking at, as I mentioned, that when you're looking at lower TSH, you're looking at if it is less than zero point 0.1, then you're a little more inclined towards thinking that it is something which requires treatment. And definitely, as Dr. Ketan Mehta said, that you have to look at the T4 level. The T4 level becomes very important there. Whereas in hypothyroidism, it's the TSH only that we are worried about. And we are looking at a value of more than 10 as a situation where most people require treatment above 10. Whereas between 10 and the normal limit is generally in most labs is about 4.5 or 5. So in that 5 to 10 range, you're deciding and treating only a few people, and particularly you're looking at the younger people and in terms of treatment. Older people you're trying to avoid treating even in that a group of 5 to 10.
Okay. There is a question which come from Dr. D.V. Menon, that what about drugs causing hypothyroidisms? For example, anti-tuberculous drug, and how to
Yeah.
regulate it. Yeah.
Yeah, there are some other drugs which can interfere with thyroid function, like PAS is particularly one drug which used to be used very often earlier, and now also used for the multi-drug resistant tuberculosis, which can interfere with the thyroid function. And then the other drugs like lithium also is one drug which can interfere, which is used for treatment of psychotic problems and all that. So there again you can have problems with thyroid hormone formation, and there you can have you may require to adjust those based on the requirement that you're seeing. So again, you should be aware of this, and you may require to treat these people. And once you stop these medications, then you have to reassess whether you have to continue treating them with thyroxine or not.
Okay. Now, you mentioned about, besides the thyroid, the next common thing which is prevalent, which is a very silent entity, which is the osteoporosis. Now, when would you recommend that, the family physician should ask their patient that beyond particular age should go for a screening? Now we have got a bone mineral density or a DEXA scan which is available. So for a male and for a female, at how frequently and above what age they should go for it?
Yeah. So this is a very another important area which is very often silent and until it presents with a consequence, that is the fracture. So when we are speaking of diabetes, when you're speaking of all these other problems, when you're speaking of diabetes, we are worried about the complications of diabetes. We are worried about cardiovascular disease. We are worried about renal disease. So just like people with diabetes can develop these problems, people with osteoporosis can develop a fracture, and fracture is very common, and it's very in the sense it increases the morbidity of the individual, in the sense that if the typical osteoporotic fractures are fractures which occur at the hip, fractures which occur at the spine, and probably also a Colles fracture which happens on the forearm, on the forearm. So these are the common osteoporotic fractures that happen, and we all know that we see a older person developing a fracture of the hip. It significantly interferes with their activity, and even after the treatment, what happens is that the treatment one is that the treatment requires a huge amount of money to be spent on the surgery that is to be done, and second thing that happens is that even in spite of all that, the people don't become half of them don't come back to the usual activity, and many times it's a beginning of the end for the person.
Right.
So I think we should keep in mind that this is again a preventable problem. This is again a preventable problem. If you start thinking about it early, we start thinking about in women after menopause. If you start thinking about their bone health and try to see that they replace them with adequate calcium and vitamin D, and so that itself can solve the problem in many of them. And then we do a bone density. Typically, a bone density is recommended to be done, say, 5 years after menopause. Okay. In the Western population, it said that you do it at the age of 65 for all women and 70 for all men. But what we see is that even in the case of osteoporosis, it's like the same as in diabetes and cardiovascular disease. That in India we tend to have these problems a decade earlier.
Right.
So we see that in men we see these problems in 60s, late 60s. We see many osteoporotic fractures, and in women probably also in early 60s and sometimes in the later 60s. So what we have to understand is that we should start thinking about it right at menopause in women, right after menopause, after the age of 60. Try to do a bone density once at the age of at 5 years after menopause, and always treat all of them with calcium and vitamin D supplementation, because the requirement of calcium goes up to the tune of about 1500 milligrams every day, and the best of the diet can also provide about 8 to 900 milligrams, and we require additional 500 milligrams to come from the from a supplement. So
Okay.
that is the reason why we require this to be done.
Yeah. Now, since the data for the prevalence of osteoporosis, which is a huge problem, and in fact, we have seen that we have a elderly or geriatric population presenting with the fractures and something preventable if we can take care right from the beginning. And as Dr. Rakesh has mentioned, there is a huge role of prevention when we are talking about osteoporosis, especially supplementing them with the calcium, vitamin D, which has a role. So, somebody now who has been diagnosed as osteoporosis by bone mineral density or anything, do you think all these patients, of course, they have been given or treated, I mean, been supplemented with calcium, vitamin, everything? Which are the other drugs which a family physician can offer or ask them what we call it for treatment already those who have established osteoporosis?
Yeah. So basically, when we're dealing with osteoporosis, we are dealing with the bone, which is not as inert as we think. I mean, in the sense, when you look at a bone, we think that bone is something. Bone is the most inert part of the body, but bone is very dynamic. Bone is constantly undergoing formation and resorption. So that formation and resorption in early life is more of formation happening, less of resorption, and then it plateaus at a particular level. Say around 30 years of age, you may say that it may plateau, and then later on, can you hear me?
Yeah, yeah,
Ah,
absolutely.
okay. Something came on my screen, so I'm just saying.
Okay, okay, okay.
Okay. So it plateaus around 30 years of age, and then later on, what happens is that at menopause again, what in women there's a steep increase in the bone resorption, while the formation is not able to match that. And while when it is happening, but gradually happening, that there is an increase in resorption, which is with the formation is not able to match up with that. So this is what is happening. So now we have got drugs which can block the resorption, which is accelerated in older age, and then we have drugs which can increase the formation of bone. So drugs which decrease the resorption, the most popular ones are the bisphosphonates, as we know. These are like the agents which are available commonly are hypothyroid, residronate, and then we have got intravenous preparation in the form of a zoledronate. So these are the ones which we have, and then there's one monthly preparation of ibandronate also. So these are the 3 or 4 different drugs which we have in this category of bisphosphonates. So they are very popularly used. The problems with the oral preparations are that they can cause esophagitis and particularly reflux esophagitis. So they have to be, when they are given, you have to advise the patient to take it on empty stomach and not lie down after taking the tablet, and then take a large amount of water along with it, and stay active, or so, say sitting or standing or doing their usual work, not lying down for at least 1 hour. So these are the things that we have to ask them to do. In spite of that, some people may have a lot of esophagitis and all that. So we have a intravenous preparation available in the form of zoledronate. So this has come in recently, and this is a once a year preparation. So that's very convenient. It can be given once in a year under supervision. They require to. That has to be given as a infusion over half an hour. So that is one category of drugs. There are other anti-resorptives available in the form of denosumab is another drug which is presently very costly. Available, needs to be given once in 6 months subcutaneously as a subcutaneous injection. So that's the other one available. And then we have we other category of drugs which interfere with have a significant effect on osteoporosis is the estrogen preparation. So somebody who's on HRT benefits from improved bone formation and decreased resorption. Again, resorption is decreased to a large extent by the estrogens. So that is another category of drugs. So we have got the estrogen receptor modulators also. You have so they are another category of drugs. We have raloxifene available in that category. So those are drugs which decrease the bone resorption, and the ones which increase bone formation are typically PTH, the recombinant PTH injection that is available, a recombinant PTH that is called as teriparatide. So PTH actually, it's interesting that PTH actually increases the bone resorption. So when PTH is very high, it causes bone resorption. So somebody who's got hyperparathyroidism will have increased bone resorption. But when it is given intermittently, it stimulates the osteoblasts and causes bone formation. So there's a difference between intermittent PTH being given as a therapy versus the high PTH that is found in the body in hyperparathyroidism.
Okay.
So that is the bone forming therapy that we can say.
Correct.
These are
Now
the
that's a very interesting aspect of parathormone which you mentioned about it. In fact, one question has come from Dr. Akhil Contractor, that what are the indications when we ask for a PTH? So should all patients of osteoporosis, should we get a PTH level then?
Yeah. So basically, if you look at, an individual having osteoporosis, the important things that the 4 important things that interfere with that, which influence that, is we get a calcium, phosphorus, and vitamin D and PTH, because vitamin D is very often found to be deficient in a large population. In large number of people, we find that, and majority of us have low vitamin D levels, and the low vitamin D actually stimulates the PTH to go up. So you have something called a secondary hyperparathyroidism seen in a lot of individuals who are vitamin D deficient, as against a primary hyperparathyroidism where the PTH is high in spite of the vitamin D levels being normal, and the calcium levels being high. So that is something which you have to keep in mind. So I think if I understood the question correctly, he wanted to know whether we need to do parathyroid levels in all people who require treatment with PTH.
Yeah.
So I think that is important, because we have to exclude any secondary hyperparathyroidism, because there could be an individual who is having low vitamin D and he is having a high PTH because of that. And if you're treating him with PTH, it's not going to help him. So
Okay.
we have to give him adequate calcium, vitamin D, get his PTH normal, and then treat him with recombinant PTH, which we are giving intermittently to increase the bone formation.
Correct. So that's again a very important message. We osteoporosis, which is a commonly preventable entity, and even if you detect it, it can be a treatable entity. So please don't ignore. You must look out in your patients and which can be treated. Okay, coming to one more entity which you mentioned about the PCOD or PCOS. So it has happened practically all young females going for a routine ultrasound. The gynecologist wants, they are planning for a family or going for it, get a basic done, and every alternate lady comes out with the PCOS. And sometime now that so much noise level is created, they feel now they will going to have a difficulty. They start thinking they will have to go for IVF, they will have to go for all the things. So can you throw some light the difference between when they call PCOD or PCOS and how to proceed when family physician sees the report accidentally? How should they go about it?
Yeah. So basically, this is another interesting problem, which is again linked to the epidemic of diabetes that we are facing. So it is in a way linked to that because what we are seeing is that the growing prevalence of diabetes also again is fueled by the increasing rates of obesity in the population, and that again is leading to insulin resistance and leading to diabetes on one side. And without diabetes, there are several other problems coming because of the insulin resistance. That is cardiovascular disease, lipid abnormalities. And women, what is happening is that because of the insulin resistance, the high insulin levels are causing disturbance in their ovarian function, leading to increased androgen production, increased production of testosterone. The ovaries, instead of producing more of estrogen, are producing a little more of testosterone. And because of that, what is happening is that they have disturbance in their cycles, and then they have a little bit of hair growth on their face and chins, and in all the androgen dependent areas they have hair growth. And what is happening is that they have anovulation because of that. So they have disturbed periods and all that. So this is what is basically the reason for that, the insulin resistance that is the reason most of the women. I mean, it's not that that is the only cause. There could be other reasons also. Stress could be another reason, because of which what is happening is that there is a hypothalamic disturbance, and that also can cause a picture like this. So, but by and large, what we are trying to understand, trying to say is that this is a uh, unlike, I mean, the PCOD used to be a earlier term that was used, where you call it as polycystic ovarian disease. But what we are seeing is that it's not like a disease; it's like a syndrome,
Syndrome.
where we speak of metabolic syndrome. It's a metabolically driven syndrome, and it is a conglomeration of several conditions, several problems, several factors, which can have variable effects in variable at different ages, and can have different connotations and can have different effects. So that's why it's not a disease as such. It's not a homogeneous disease, but it's a syndrome. So that's why we prefer to use the term PCOS now rather than PCOD. That is one thing. Second thing is that the other important thing is that what we have to understand is that to diagnose PCOD, what we require is that I mean, cysts in the ovary always don't mean PCOS, because cysts can be present even in normal women. 20% of normal women also who have no other features of PCOS, that is, who don't have the insulin resistance, those who don't have ovarian dysfunction, they can still present with the picture of multiple ovarian follicles. So that is not necessarily which means that not every woman who has this ovarian picture has got PCOS. So PCOS means coming, I mean, the three factors there being there. One is the ovarian dysfunction, that is anovulation. Then second thing is that means that they have irregular periods and don't ovulate regularly. Second thing is they have features of hyperandrogenism, that is excess of androgen. That could be clinical features in the form of hair growth and all that, acne, hair growth, hair loss in, I mean, recession of the hairline and all that. And third thing is the ovarian picture which you are seeing. So if they have got all the three, then you call it as PCOS. So not everybody who has this ovarian appearance on the ultrasound has PCOS. So that's another important thing to be kept in mind.
That's a very important message which you have given, because otherwise today's time the radiologist starts diagnosing saying cyst in the ovaries and labeling as PCOS, and then creates a panic situation for the young lady who is planning a family and all. So a very important message for family physician: every cyst in ovary is not PCOS. So please don't label it. It need to be correlated with the clinical features. That's a very important message. And don't make them psych or panic them that they will have a problem in conceiving or for planning for a family. So that's a very crucial message. The another point is, now the trend is obviously when they go to a gynecologist, they get a sonography, then they ask for certain hormonal assess, of which one level when before pregnancy they are invariably asking serum prolactin levels, and quite a few of them will come with serum prolactin levels slightly elevated. Now, can you throw how, because what happens, they will go back to family physician saying that I have got a prolactin level high. I mean, that no, that these hormones is going to increase only in the lactating lady. Now how come this is high, and how should they go about it?
Yeah. So prolactin is another important, very important hormone to be understood. The points that we need to understand about prolactin is that prolactin, the level of prolactin is very important to understand. I mean, when somebody has got hyperprolactinemia, they often present with amenorrhea. That is, they don't have, their cycles are not they have absence of cycle or 3 to 6 months. Whenever the prolactin level goes up, so it's important to check for the prolactin level whenever you're dealing with a woman who has got say secondary amenorrhea, that they're not having their periods for a few months. Then you need to check their prolactin level, and also always have to check thyroid hormone levels. That's a very important thing that has to be done. You have to check the thyroid hormones and also the prolactin. Don't ever measure only the prolactin, because one of the important causes of hyperprolactinemia is the hypothyroidism itself. The high TRH causes the prolactin to go up, because in primary hypothyroidism, what is happening is that the just like the TSH goes up, the TRH also goes up, and that TRH is a stimulant for the prolactin to increase. So, and treatment of hypothyroidism will correct the prolactin also. So that's why it's very important that whenever you see any prolactin level, look for the immediately look for the thyroid hormone levels. Immediately look for TSH. Search for the TSH. If it is not already done, get it done. If it is normal, then only you think of whether you need to treat that, not to treat that. Think of all that later on. First, look for the thyroid TSH. If the TSH is not done, then get it done. If it is done and if it is normal, then only think of treating it. Now, the other important point about prolactin is that we could say that there are three categories of prolactin levels increasing. So it can increase because of any sort of stress, any small stress, even the stress of puncturing the vein and taking out the prolactin, taking out the blood sample will increase the prolactin level. So prolactin is very sensitive, as a sensitive hormone, which increases with just any form of stress. So that is important to keep in mind. Renal failure is another condition where prolactin goes up. Hypothyroidism, as I mentioned, is another condition. So all these will cause the prolactin to be just marginally elevated. Like, normal level is say to about 20, 29, 25 or 30. And if you have something 50, 60, up to 50, 60, it's because of these reasons. When you have something above 100, then it indicates that it is because of a tumor there. It could be a microadenoma, or a larger tumor can have more than 200. If you have a product level more than 200, it is because of larger tumor. So this is one of the conditions where the hormone level correlates with the etiology that is there. Otherwise, you don't generally have this. I mean, the etiology does not correlate with the levels of the hormone. And the second, another important thing is that you have a lot of drugs, antipsychotics, even the what you're using, the proton pump inhibitors,
Yeah.
domperidone, and all these things can interfere, can cause the prolactin to go up. Lesuride and all these, and with the motility altering agents, which are acting through dopamine receptors. So they all interfere with the prolactin, and all of them will have prolactin less than 100 in the 60, 70 range. And those are all, just stopping the drug will get the prolactin back. So these are important points that has to be kept in mind, and you should not be suddenly worried about what having a high prolactin. You should first get a thyroid level done, ask for drugs, history of drug intake, and then get the others.
Correct. So you said nicely about looking out for the cause for the prolactin levels. Now, initially, you mentioned about the secondary causes of hypertension and especially endocrine causes. So, quite often, a person who is presenting for the very first time and very young patient, where definitely you would like to look for a secondary cause. So, can you just list the endocrine secondary cause of hypertension, which the people should keep it in mind?
Yeah. So if you come to hypertension, I mean endocrine causes of hypertension, we
Yeah.
can say that there are two or three important uh, reasons that we have to keep in mind. One is pheochromocytoma, which is probably presents with a typical presentation of where they have this where they have these spells, where they have spells of headache, palpitations, and sweating, and the very high blood pressure. So these are the typical spells they have of your chromocytoma. And one of the important things that you have to keep in mind is that the hypertension may be persistent in such people also, because often we see that they have hypertension only when they have the spell. They have a very high blood pressure. In between, they may be normal. So that is the usual presentation. But many of them can be continuously hypertensive. I mean, they can have the blood pressure persisting throughout all the time, and they can still have these spells. They may not have the spells also. So that is something which has to be kept in mind. One important thing about fuels is that we should keep in mind is that they have a significant postural drop in blood pressure because they have a volume depletion. They'll have a significant drop in their blood pressure when they stand up. So when they're say standing up from a sitting position, or from a lying down position, you find that there's a postural drop in significant postural drop in blood pressure, and that is not related to any medication that they're taking, but it is related to the problem itself. So that is one condition which you should keep in mind. And I think we have good tests for doing that. And the commonest test nowadays, more than doing a VMA, what we would like to do is do the urinary metanephrin, because they have much higher specificity and sensitivity for picking up few chromocytons, and lesser interference with many of the substances which used to interfere with VMA measurement. And the second most common, I would say, is primary hyperaldosteronism. Now is becoming a very well understood entity, which earlier we used to think was very rare, but now we are understanding that it is more common than what we used to think. And many people with very high blood pressures, which are not easily controlled, have this problem. And in fact, some of the Western series have shown that it may be as high as 10% of all hypertension. But we have not yet found that high prevalence in India. But I think this is something which we have to keep in mind.
Yeah, and that is how we have been now using, of course, aldosterone antagonist, which has been quite frequently used as a diuretic in third line or a fourth line antihypertensive before we label them as a
Very good.
refractory hypertension also. So that's a very good. So before we end, I would you to give a message to our delegates about what are the red flag signs or symptoms which this family physician should keep it in mind in respect to endocrine disorders, where they should not wait and should refer immediately to an endocrinologist or to hospital. So red flag signs you think they should keep it in mind in endocrine practice.
Okay. So if we look at red flag signs, I would say is that when you're dealing with hyperthyroidism, if you're dealing with hyperthyroidism, particularly if you've got a significant orbitopathy, if you've got a significant eye disease, then that is something you can send it to an endocrinologist to manage them. You could manage the other I mean large number of other hyperthyroidism who don't have a significant orbitopathy. I think this is another. I mean, because that increases the complexity of management. So I think that is one area. Then thyroid I mean, coming to hypothyroid problems, I think hypothyroidism in children, where in the growing age, probably they require more frequent monitoring and all that. So that is one area. And hypothyroid disorders in pregnancy is another area, which I would say are areas which, I mean, are situations which require a little more intensive monitoring, and you may not have that much time, and sort of you may not get so much time to take care of these people. You can obviously, I mean, take the help of endocrinologists, discuss these issues, and keep yourself updated and manage many of them. But maybe you may find it easier to send across. And then I would say that as we discussed about uh, those requiring therapy in osteoporosis, you could do the screening, identify those who have got severe osteoporosis, and where you want to treat them adequately and prevent fractures. I think that is one area. And then we have got situations like hyperprolactinemia, where which is not because of drugs or which is not because of hypothyroidism, where you have got a tumor there, and any pituitary tumors that you encounter, those are situations probably I think you can. And we didn't discuss about syndrome. I think that's one area which many a times is very difficult to interpret the tests and understand where the etiology is and identify the cause of the problem. So that is one area where even endocrinologists often struggle to understand where the problem is and what should be the best solution for that. So I think those are areas which are the red flag signs which require a referral immediately.
So, dear friends, we know now that in endocrinology, beyond diabetes, there are a lot of factors and a lot of conditions which we should be aware about, and which today has been made very clear by Professor Dr. Rakesh Sahai. He has given thrown lights on various aspects which we have seen in, and all of us are seeing in day-to-day practice. So I am so much thankful to Dr. Rakesh Sahai for sparing a valuable time in his busy schedule and giving us the time and enlightening our delegates for these unanswered questions in endocrinology. And before we go for a vote of thanks, I would invite Abhishek from InnoCare to say a few words. Abhishek, are you there? Hmm. Yeah.
Hi, and good evening to all the participants. Myself, Abhishek Davish, working in the marketing team at Innovcare Life Sciences. This webinar is organized by Innovcare Life Sciences Private Limited with the help of IMA Mumbai West to talk about the expert talk show. It is important to understand, the unique and the special show that we will be conducting. It's a knowledge sharing platform for experts as well as young doctors. The perfect mixing and the mingling done by Dr. Mehta when it comes to striking the right balance between the basic questions and advanced questions. Not only from India, but doctors from across the globe are getting benefited from this show. Till now, in expert talk show, we have invited multiple specialties like ortho, rheumatologist, cardiologist, diabetologist, pulmonologist, nephrologist, and so on to continue. Talking about Innovcare Life Sciences is a 6-year-old Mumbai-based company with more than 500 people working in it, operating across the India. We are present all India, and you can get all the details at Innovcare website, which is www.innovcare.in. You can also follow us on Facebook, Twitter, and Instagram. We at Innovcare are always on the forefront when it comes to support the medical education across the specialties. And we are also proud makers of brands which are showcased here, CDZ and T3, D3. Innovcare Life Sciences is known for the innovative brands. To talk about Series Z, rather, I would say it's a combination of vitamin C 500 milligram, vitamin D3 400 IU, and zinc sulfate 27.5 milligram. Now, this is the combination which is being used a lot in today's scenario to prevent the acute respiratory distress syndrome and prevent the viral replication. Also, we have product called T3, D3, which is a combination of tocotrienols, the superior form of vitamin E, along with vitamin D3 2000 IU in a daily dose, with the full dose of methylcobalamin, L-methylfolate, and vitamin B6. From entire Innovcare Life Sciences family, we would like to say a big thank you to Dr. Rakesh Sahai sir and Dr. Ketan Mehta sir for giving valuable information and insights related to the unanswered questions in endocrinology for family physicians beyond diabetes, of course. Thank you so much, sir, for your time. It was a pleasure to have you with us, sir. Sir, over to you, sir.
Yeah,
Thank you.
thank you, Abhishek. And now I will request.
Yeah, Dr. Ketan Mehta, I will say one line.
हाँ,
आज का प्रोग्राम हमारे लिए बहुत बड़ा सहाय है एंडोक्राइनोलॉजी सीखने में.
Thank you. Thank you.
I hand over the mic to Dr. Akhil, contractor, for Thanksgiving.
Yes.
Well said.
Good
sir.
evening, friends. Our great thanks to Professor Rakesh Sahai and Professor Ketan Mehta. Two professors together really made a wonderful program today. I think there are many, many points which are always understood and still over understood and sometimes under understood. So we cleared all the doubts. So thank you very much. And when we talk about Hyderabad, we remember Hyderabadi biryani. So maybe next time we'll have in Hyderabad sometime.
Thank you.
We thank all our delegates for attending in large numbers. Of course, we thank Innova Care for all the support. And just to remind you, friends, of tomorrow's program, it is again a very important program of nutrition. Ketan Mehta, Dr. Manoj Chawla, and Dr. Keyur Dave are going to take the lead. And it is an accredited program. It will start at 10:30 and end at 1 o'clock. So we request everybody to join, and we'll request Professor Sahai to again meet us, if not in Mumbai, in Hyderabad. Thank you, sir.
Thank you, sir. Thank you. Thank you, sir. Thank you.
Thank you very much. Thank you, Dr.
Thank you. Thank you, everybody. Thank you. Thank you.
And Dr. Contractor for
Thank you, sir. Thank you, sir. Sai, sir. Thank you, sir.
Thank you.
Captain, thank you. Thank you. Thank you.